Yeah, Revati and Suchika, you can start now.
Good evening, everyone. A very warm welcome to this ISA National online PG class. These classes are held on Mondays and Tuesdays. I am Dr. Ruchika Nayak, currently working as Senior Resident in Department of Anesthesiology, JNMC, Belgavi. I will be the screen coordinator for today. In today's session, we'll be discussing about biliary atresia for Kasai procedure. Before we start with today's class, let us invoke the divine blessing of Goddess Saraswati with the Saraswati Vandana. I will now request Dr. Sukhmendra Sir, who is on the Honorary Secretary of ISA National, to address the audience. Over to you, sir.
Thank you, Dr. Ruchika. I think today's class is one of the most challenging class. It's mixed with so many difficult situations. First of all, you are getting a neonate and you're going for a surgical process, a process which is also very delicate, require highly skilled surgeons to manage that. But the most important will be the anesthesiologist in a young child of a neonate, and you're going for a procedure, and that too such a complicated, lengthy procedure with the liver dysfunction, whether you do at the neonatal stage or at a later stage, whatever stage you do, but the liver is almost getting a compromised. And being a master organ, I think that's the is controlling the growth, controlling so many things, controlling your metabolism, toxicity, everything. So in these patients, when you are giving anesthesia, you may not be knowing to what variable level this liver will be functioning to metabolize your drugs, to maintain how you can maintain the anesthesia without causing much harm to the this neonate or the child. And also there are other problems like airways and temperature. Those are the normal complications and difficulties you encounter in these patients. So, moreover, it is a very, very challenging procedure, and the drugs titration is very important. How you keep record of a plasma levels of drug, it's very difficult to measure also. You are depending more upon your this clinical acumen and monitoring gadgets, whatever you've got. But in dynamic situations, what is happening inside the vasculature, and how about the liver, how the drugs are getting transformed, how they're getting to the kidney, it's very, very difficult. And I think Dr. Vijay Lakshmi, Madam, and her team must be having answer to many of these queries, which everybody should be enjoying during this class. So, Ruchika, back to you and take the class forward so that we are very eager to hear to the what the team has to say.
Yes.
Thank you, sir, for your kind words. Good evening. I am Dr. Revati Ashok, Senior Resident in the Department of Anesthesiology, Sri Devladas Medical College, Kolar, and I'll be the screen moderator. We have amongst us our esteemed faculty moderators for today's PG presentation, Dr. Vijay Lakshmi ma'am and Dr. Vrinda ma'am. Dr. Vijay Lakshmi is the additional professor and head in the Department of Anesthesiology and Critical Care, AIMS Bilaspur. She has a teaching experience of more than 17 years. Her special interests include ultrasound-guided regional anesthesia, point-of-care ultrasound, pediatric anesthesia, difficult airway, critical care, and transplant anesthesia. Her achievements include starting a 12-bedded CCU in AIMS Bilaspur in January 2024 and a renal transplant anesthesia unit from October 2024. Her awards include ISA Jaipur Award paper in ISACON 2019 and second best faculty e-poster in Research Society of Anesthesiology Clinical Pharmacology Conference in 2025. Her publications, she has 14 publications in her name and one chapter in her book. Welcome, ma'am. Our next faculty moderator is Dr. Vrinda Chauhan. She is an assistant professor in the Department of Anesthesiology and Critical Care, AIMS Bilaspur. She has a teaching experience in post-graduation for 4.5 years. Her special interests include pediatric anesthesia and difficult airway. She has 4 publications to her name and 8 chapters in books. We welcome you both, ma'am. Before we begin, there are certain rules to the class, which my co-screen coordinator will be enlisting.
All students are requested to kindly turn off their video and audio as well. And all queries can be typed in the chat box, which will be addressed towards the end. Towards the end, the students and faculty members can raise their hand to speak a few words with or ask questions to the uh, moderators and PG students. Thank you. Now over to the faculty members. No?
Okay, a very good evening, Bajwa sir, Madhuri ma'am, and everyone who have joined online. I would like to introduce our postgraduates who would be presenting today. It is Dr. Harshita. Please raise your hand. She's our final year postgraduate in the department, and Dr. Shreya Prakash, who's the first year postgraduate in our department. So second year postgraduate in our department, sorry. And both of them would be actually doing the case presentation as we go through. Let us at each step go through a few things and then discuss certain points. So biliary atresia basically is an obliterative cholangiopathy, so of infancy, and if we don't treat it at the right time, that might get deteriorated and it leads to an end-stage liver failure also. So the procedure as such is a palliative procedure. The ultimate thing is a liver transplant. We are not going there today, but I think we can straight away start off with the case presentation. Over to you, Ashita.
Yes, ma'am. Good evening, sir. Good evening, ma'am. I'll start the screen sharing.
Good evening, sir. Good evening, ma'am.
So we are presenting a case of 2-month-old infant with biliary atresia.
Two-month-old term female child with informant being mother brought to hospital with complaint of yellowish discoloration of eyes and skin. 2 months old term female child with informant being mother brought with complaints of yellowish discoloration of eyes and skin since 7 days. Dark colored urine since 7 days. History of presenting illness. The baby was apparently all right 7 days back. Then she started developing yellowish discoloration of eyes and skin, extending till palms and sole, which was noticed by her mother. She also noticed that baby is passing pale colored stools and dark colored urine. There was no history of fever or seizures, no history of bleeding from injection sites, no history of sweating during feeding, no history of bluish discoloration of skin, no history of similar complaints in family or parents or siblings, no history of decreased appetite, no history of phototherapy or abdominal distension or illness. For the above complaint, baby was taken to Government Hospital Dharamshala, where blood investigations, direct bilirubin 7.4 and indirect bilirubin 1.7, and ultrasound of whole abdomen was done, which was suggestive of cystic lesion in segment 5 of right lobe of liver, query choledochal cyst. And then from there, she was referred to AIMS Bilaspur for surgery. Obstetric and birth history. Antenatally, a second child born out of non-consanguineous marriage, mother was on regular antenatal checkup. Antenatal scans did not show any congenital abnormality. No history of fever with rash during pregnancy. Birth history. Full-term normal vaginal delivery of female child weighing 2.4 kgs, cried immediately after birth. No history of neonatal intensive care unit admission, discharged on day 2 of birth. Developmental history. Social smile present, recognizes mother, alert to sounds. Immunization history. Immunized with BCG, OPV, hepatitis B, pentavalent vaccine, rotavirus, and IPV. Nutritional history. Baby is exclusively breastfed, accepts feed well. Surgical history. No previous surgical history. On general physical examination, baby was done after obtaining consent from the parents. Baby was active and playful. Faces appeared normal. Icterus present. No pallor, cyanosis, lymphadenopathy, or edema. No obvious skeletal deformities was present. Length was 58 centimeter. Weight was 3.8 kgs. Vitals. Temperature afebrile. Pulse was 128 per minute, regular in rhythm, normal volume and character. Respiratory rate 35 per minute, bilateral air entry equal, normal vesicular breath sounds, regular abdominothoracic pattern, and no subcostal recession was seen. Saturation was 98 to 99% on room air, and capillary refill time was less than 3 seconds. Head-to-toe examination. No gross dysmorphic features were seen. Anterior fontanelle as well as posterior fontanelle open and was felt. Skin was yellow in color, no scars was present, no signs of bruising. On systemic examination, cardiovascular system, heart sounds S1 and S2 were heard, and no murmur was present. On respiratory system examination, bilateral air entry equal, chest was clear, and no added sound, and no subcostal recession was present. Central nervous system, baby was alert, active, and playful. On abdominal examination, on inspection, abdomen looks normal, no visible dilated veins or ecchymosis, flanks are free. On palpation, soft, no local rise of temperature, no tenderness, no hepatosplenomegaly, regular and rounded lower margin fell 2 centimeter below right costal margin at mid-clavicular line. On auscultation, bowel sounds were heard. Summary. 60 days old female child born to non-consanguineous parents, full-term present, weight of 3.8 kgs with jaundice, dark-colored urine, and pale-colored stools from last 7 days. No dysmorphism, coagulopathy, or ascites. No hepatosplenomegaly. A case of neonatal cholestasis, most probably biliary atresia.
Okay. So we'll stop there at the summary slide. Dr. Shreya, go back.
Yes.
So we'll have few questions on this. Okay.
Okay, so go back to your history taking slide where you have taken negative history.
The negative history.
Yes,
Yeah.
ma'am.
So first of all, when you are saying no history of fever in such a case, so what do you mean by, what are you ruling out, or what do you mean to say by no history of fever in this case especially?
Ma'am, by this specific history, we want to rule out cases or conditions presenting with fever in presence of jaundice, like cholangitis. It could be an upper, and then it could be this UTI also, urinary tract infection, then hepatitis, and neonatal sepsis.
Okay.
Okay.
Then why is no history of bleeding from injection sites important in this case?
Ma'am, because in the involvement in biliary atresia or a neonatal cholestasis, when there is a involvement of the hepatocytes, there in the later or advanced stages, often coagulopathy is seen, and which can lead to bleeding. And so by asking such history, we can rule out if there was a bleeding tendency on intramuscular injections, or if there was a hematoma formation in the past.
Why are you expecting coagulopathy in this case?
Ma'am, because The clotting factors are mostly synthesized by liver, and bile helps in the fat emulsification and thus absorption of fat soluble vitamins like vitamin A, D, E, K. So, and some clotting factors like 2, 7, 9, 10 are mostly vitamin K dependent.
Okay.
So it will all lead to coagulopathy.
Okay. And then by history of distension or fullness, what are you ruling out?
Ma'am, by history of distension, we're going to rule out if there were any features of hepatosplenomegaly or portal hypertension, which is often seen in the later stages.
Okay.
Ascites also.
Ascites also.
Okay.
No.
So, what are your DDs in this case? Why are you saying probably this is a case of biliary atresia? How will you support your diagnosis?
Ma'am, first is because she's a female child, as female preponderance is more in case of biliary atresia. Second, the baby is well fed, is accepting feed well, well thriving. And ma'am,
Ma'am,
What are the
and
points favoring your
Points
biliary
favoring.
atresia? That's what we are asking.
yes, ma'am.
Your history.
Yes, ma'am. The baby is female. It is from she's from non-consanguineous marriage. She's accepting feed well.
What
Well
else?
thriving. No weight loss. There is no history of weight loss or decreased weight for age.
And ma'am, the classical triad of biliary atresia, that is jaundice and the acholic pale colored stool, as well as dark colored urine, is also seen in this case.
Yeah, okay. Okay, so what could be the other DDs and what are the other DDs you are keeping in mind? As you're saying, the patient was referred from Dharamshala with the ultrasound findings of some cystic lesion, which probably it was query choledochal cyst you are saying now.
Yes, ma'am.
So what other conditions come to your mind?
Apart from biliary atresia, other DDs can be choledochal cyst or inspissated bile syndrome, or it can be spontaneous bile perforation, or it can be Alzheimer's syndrome, then bile duct stenosis.
Okay. Move to your examination slide. Okay, so when you are doing a general physical examination or head-to-toe examination, so what is the importance of doing head-to-toe examination in a small infant or a child?
Ma'am, by doing head-to-toe examination, we are assessing the growth of the baby, the nutritional status, and also the severity of the disease. As we go from head to toe, in head we can see anterior and posterior fontanelles, which in this baby will be open. We can assess the eyes raised if there's any
Before
raised eyes.
fontanelles, you have written no gross dysmorphic features of faces. Any importance of this line or any importance of faces or no gross dysmorphic features, especially in this child?
Ma'am, neonatal cholestasis, there is a DD's Alagille syndrome, which has dysmorphic features like triangular faces, broad forehead, pointed chin. So we are ruling out that thing.
Okay, and other
And also Down syndrome also can present with neonatal cholestasis. So the classical moon facies of the Down syndrome, we can also rule out syndromic facies.
rare, but yes, Downs can also present. Then okay, when does you're saying about anterior and posterior fontanelle? When does it closes anterior and fontanelle?
The anterior fontanelle closes around 12 to 18 months of age, whereas posterior fontanelle will close around 2 months of age.
Okay.
Okay. Coming to the next slide, where are your vitals, where you mentioned the CRT. So how do you check for CRT, capillary refill time?
On the capillary refilling time, we are usually checking in sites like sternum, forehead, arms, soles, and nail bed. I'll apply a gentle pressure on sternum for 5 seconds, and then I'll release the pressure, and then I'll see the return of color, and I'll count the seconds. If it is less than 3 seconds, it is normal. If it is more than 3 seconds, I'll consider it as prolonged capillary refilling time.
Okay. And what is called physiological jaundice of the newborn?
Physiological jaundice of the newborn is it's physiologically present in every newborn because there is increase in RBC turnover in the fetal life, and And also after birth, there is RBC lysis. There's also average RBC lifespan decreases to average 60 days. So, and there is increase in perihepatic circulation. Also, there the liver enzymes are immature. All of these leading to unconjugated hyperbilirubinemia, and this presents after first 24 hours of birth, and it doesn't last beyond 2 weeks of age, and no treatment has to be done in this case because it goes away on its own.
In biliary atresia, is it unconjugated or conjugated?
Conjugated.
Conjugated, yes. So what is the other one called breast milk jaundice? What is this?
Ma'am, breast milk jaundice, it usually occurs, peaks around 5 to 7 days of birth. And this is usually due to certain factors which is present in breast milk, like pregnein 3-alpha 20-beta-diol and beta-glucuronidase, which all helps in the deconjugation of the conjugated bilirubin in the intestine, leading to more formation of unconjugated bilirubin. So this will present as an unconjugated hyperbilirubinemia in these neonates. And
it stays till when? What duration?
Ma'am, it will last till 2 weeks only. It won't go beyond 2 weeks.
Yeah, beyond 2 weeks. So what are the causes of neonatal cholestasis? Can we just share our slide so that you will tell the details of neonatal cholestasis?
Yes, ma'am.
Yeah, please. Yeah, what are the
neonatal cholestasis can be extrahepatic or intrahepatic. In extrahepatic, we have biliary atresia, choledochal cyst, spontaneous bile duct perforation, and Alagille syndrome. And in intrahepatic, we have multiple causes like infectious, we have torch infections, UTI, and viral hepatitis. In metabolic, we have tyrosinemia, galactosemia, cystic fibrosis. In endocrine, we have hypothyroidism. In TPN, total parental nutrition associated or drug induced, we have ceftriaxone-induced hepatitis, then chlorpromazine. In idiopathic or miscellaneous, we have idiopathic neonatal hepatitis and mitochondrial hepatopathies.
Okay, so when we see this next one, what is the metabolism of bilirubin? Basically, steps of the breakdown. Wait 1 minute.
The bilirubin metabolism is divided into 4 phases, which are named as breakdown, conjugation, alimentary phase, and excretion phase. So what happens in the breakdown phase is heme, which is formed from the breakdown of hemoglobin and other heme-containing proteins like cytochrome and myoglobin. It is all, then that heme is taken up by the reticuloendothelial cells, where it is acted upon by the heme oxygenase to convert it into biliverdin. And biliverdin is acted upon by biliverdin reductase to bilirubin, which is unconjugated form, and it is lipophilic. So this is taken by, binds with the albumin and is taken up by the hepatocytes via carrier proteins. In the hepatocyte, where the conjugation happens with the help of UDP glucuronidase transferase, is a liver enzyme, and conjugated bilirubin, which is hydrophilic, is formed. And this is excreted into the canaliculate system via MRP2 channels, and it goes into the intestine, where the alimentary phase happens, where the bacterial beta-glucuronidase enzyme acts on the direct bilirubin and deconjugates it into
unconjugated
bilirubin, mainly in the form of urobilinogen and stercobilin. Stercobilin passes in the stool, and it gives the characteristic color of the stool, and urobilinogen goes excreted via urine. And some of them, the unconjugated bilirubin, is reabsorbed into the hepatic system via enterohepatic circulation.
So here, after the summary slide, we'll once you finish this, I would like to share some MCQs for our participants. We wish that they would also actively participate. And yeah. So can someone answer at the end of this, the main pathophysiological concern in biliary atresia is what? Is it hepatic encephalopathy, cholestasis, and progressive liver failure? Is it portal hypertension alone or acute pancreatitis? We'll just watch for maybe 10-15 seconds, see if any answers are there. Dr. Ruchika and Revati.
Yes, ma'am. Ma'am, there are two people who have answered. They've answered it as B. Most of them have answered it as B, ma'am.
Okay, that's good.
Cholestasis and progressive liver failure.
Yes, exactly. So cholestasis and progressive liver failure is the main pathophysiological concern in biliary atresia. That is the reason why you intervene in between and go ahead with your palliative procedure so that they don't go further into other liver failure status. Okay, what happens? Cholestasis, there will be activation of inflammatory mediators. Further, it will lead to fibrosis and then cirrhosis. Okay, so next, another question. What is the triad of biliary atresia? Please let us know any good answers, correct ones.
3-4 people have answered, ma'am.
Wait,
They're all
wait.
answering as
Just
A.
wait for 10
Wait,
seconds.
Dr. Revati, give them some more time to answer.
Give 10 to 15 seconds
Yeah,
time. Then
give
we'll-
them some more time.
Yeah, any answers?
Everyone has answered as A, ma'am. Icterus, pale
good.
colored stools, and dark colored urine.
Okay, that's the answer. So icterus, it would be progressive in nature. And mostly, as we already discussed, it is conjugated hyperbilirubinemia if you actually investigate it further. And pale color stool because the stercobilinogen is not formed. And dark colored urine because of the Shreya. What is the dark colored urine because of what?
Ma'am, it is
Urobilinogen.
urobilinogen.
No, urobilinogen is not coming. That is not the one. It's the conjugated bilirubin which is excessive. No, that is excreted.
it's
to the
water
kidney. That is
soluble.
why is the yes.
Yes, ma'am.
That is why it is dark colored urine. Okay. So the next question. Jaundice, it is defined as pathological when it lasts more than how many days or weeks? We'll just wait 15 seconds. Okay.
Ma'am, most students have answered it as B, 2 weeks, ma'am.
Okay. So that is 2 weeks exactly. So within 2 weeks, what you're expecting is, as we have already discussed, either it is the breast milk jaundice or the physiological jaundice of the newborn, which will be settled by that time. So see, the purpose of the first few slides is solved that they have answered well. So let me stop sharing. So Shreya will continue with her presentation. Please share. Yeah, go to the slide after summary. Start from there. Now, how do you investigate? Please start.
Ma'am, hemoglobin, CBC hemogram was done. Hemoglobin was 12.12 gram per deciliter. TLC was 11,000. Platelet count 3,05,000. Bun and serum creatinine was 6 and 0.2 mg per deciliter respectively. Sodium was 132 millimole per liter and potassium was 5.1 millimole per liter. Bilirubin total was 8.3, direct 6.4, indirect was 1.9. AST 70 units per liter, ALT 22, ALP 799 units per liter, PTINR 12.1, 1.01, APTT 32.3 seconds.
What was the GGT? Go back, please.
158 units per liter.
Why is it important?
Ma'am, it is an indicative marker or a confirmatory marker of cholestasis as it is produced in the bile canaliculi only. If its level is increased in the blood, it indicates there's some obstruction or some blockage in the bile system, biliary system.
Okay, and ALT, AST?
Ma'am, ALT, AST, they are indicators of hepatocyte injury. If there's some hepatocyte injury in the liver, and at that time, these levels are increased.
And ALP?
It signifies cholestasis as well as biliary epithelial function. Normally,
it's also increased in other conditions
Other
like
conditions.
liver, bone.
Bones,
Bone,
muscle
hump.
So
injury.
it is not specific. Which
Yes,
is
not-
the most specific one among these investigations?
GGT, ma'am.
Gamma
Gamma
glutamyl
glutamyl transferase.
Okay. So next. Go to the next slide. Yeah.
Chest X-ray was done, which was normal. USG whole abdomen, normal size, shape, morphology, and ecotexture of liver. Cystic lesion of size 13 into 12 mm is seen anterior to the main portal vein in segment 5. Gallbladder contracted. HIDA scan, hepatobiliary immunodiastatic scan was done, which suggested no significant radiotracer, visualized the bowel loops till 24-hour delayed. Static image. Radiotracer is visualized in bilateral kidneys and urinary bladder after 1 hour. Intraop cholangiogram was done.
So here, what are the causes of conjugated versus unconjugated hyperbilirubinemia? Just let me share my slide here so that you can tell in detail about what all could be the causes of this unconjugated and conjugated.
Yes, ma'am. I'll stop sharing.
Yes, please.
Ma'am, conjugated and unconjugated. Conjugated could be hepatic as well as extrahepatic. In extrahepatic, biliary atresia and choledochal cyst. In hepatic, there's sepsis, hepatitis B virus infection, torch, inborn error of metabolism like galactosemia, tyrosinemia, alpha-1 antitrypsin deficiency, drug, TPN, etc. In unconjugated, it can be physiological, as we saw in physiological jaundice of newborn and breast milk jaundice. And pathological, it can be non-hemolytic, and hemolytic can be intracorpuscular and extracorpuscular. Non-hemolytic cephalhematoma, polycythemia, sepsis, hypothyroidism, Gilbert, and Crigler-Najjar syndrome. Intercorpuscular hemolytic spherocytosis, elliptocytosis, G6PD, and thalassemia. And extracorpuscular hemolytic, avio incompatibility, RH incompatibility, splenomegaly, and sepsis.
So in our case, we are looking at conjugated hyperbilirubinemia and we are thinking in terms of biliary. Okay, what are the normal levels of bilirubin that you expect?
Ma'am, normal levels of bilirubin, total bilirubin is 0.2 to 1.2 mg per deciliter. In case of direct bilirubin, it is 0 to 0.3, and indirect is 0.2 to 0.7 mg per deciliter.
Okay. Someone among you can describe, one of you, regarding the anatomy of liver as well as the biliary tree, please.
Ma'am, the liver is made up of many tiny lobules, which are small hexagons, and each lobule has a central vein in the middle. And ma'am, surgically, it has been divided into various segments.
Yes.
From segment 1 to segment 8. And each segment acts as a functionally independent unit and has its own blood and bile supply. Anatomically, microscopically, it is made up of a classic lobule, which has central vein in the middle. And at every corner of the hexagon, there's a portal triad, which is comprised of bile duct, hepatic artery, and portal vein. And from the corner to the middle runs sinusoids, which has this Kupffer cells and endothelial cells. And this Kupffer cells helps in RBC, are phagocytic cells, and helps engulf the RBC lyse product coming from the spleen. And also blood is drained from the portal triad towards the central vein. So it is a centripetal flow, while the bile drainage is from the central vein towards the periphery and is a centrifugal flow. And hepatocytes are also arranged in plates, and in between the hepatocytes and the sinusoid is a space called space of Dissay, which has eto cells and eto cells.
Normally they are dormant, but in conditions like they become fibrosed.
Because ma'am, they are a storage of vitamin A, and in features in inflammations, they become myofibroblast, and they cause fibrosis and eventually cirrhosis of the liver.
Okay.
And
So what is zone 1 and zone 3? What are these importance?
ma'am, zone of the acinus. The functional unit of liver is the acinus, and it is divided into 3 zones: zone 1, 2, and 3. Zone 1 is the periportal zone, that is around the portal triad, and it gets the most amount of oxygen supply. And zone 2 is the middle zone, and zone 3 is around the central vein, and it is the central lobular zone, and it gets the least amount of oxygen supply, and it is most prone to hypoxia, ma'am.
Okay. So most prone to hypoxia is which one?
Zone 3,
3.
ma'am.
Okay. And most prone to hypotension and
Zone 1.
zone 1. Yes. So how is the biliary tree formed? Explain it.
Yes, ma'am. Ma'am, the hepatocytes, the endothelium of the hepatocytes, make the bile it is secreted into the canaliculi, and further it goes into the intestine via the interlobular ducts. With interlobular ducts drain into the right and left hepatic duct, which joins with the, and gallbladder has a cystic duct, and both of them join to form the common bile duct, and it drains into the duodenum of the small intestine.
Okay. So can we tell me briefly about the functions of the liver in brief?
Ma'am, liver has various functions. First is metabolism. It helps in metabolism of drug, proteins, carbohydrates, lipids. And second is it has phagocytic action through Kupffer cells. The Kupffer cells will phagocyte the bacteria, which the portal veins, the blood in portal vein is coming along. And then it has some synthetic functions, like it helps in formation of clotting factors. Liver is responsible for formation of all the clotting factors except factor 8 and wall-Willebrand factor. Apart from that, it helps in formation of albumin, transport proteins like ceruloplasmin and transferrin. It helps in formation of certain anticoagulants, also like protein C and protein S. And also, it is a storage of that fat-soluble vitamins, A, D, E, K.
Okay. So what about drug metabolism?
Ma'am, it metabolizes drug by two phases. The enzymes in two phases in the phase 1 and phase 2 reactions.
Okay.
So now that you have talked about biliary tree, so can you tell me about the classification of biliary atresia?
Yes, ma'am. Ma'am, biliary atresia is classified on basis of 2 parameters. The first one is anatomical involvement, and that is a OHI classification. It is divided into 3 types. Type 1, type 2 has 2 subtypes, 2A and 2B, and type 3. Type 1 is where it occurs in 5% and affects only the common biliary duct. Type 2A involves the common hepatic duct. Type 2B, common hepatic duct plus common biliary duct plus cystic duct. And type 3 is the most common, occurs in more than 90% of cases, and affects the whole hepatic biliary system, including the right and the left hepatic duct mass. And based on the time of presentation, it can be the fetal form and the postnatal form. And postnatal form is more common, occurs in 90% cases, and fetal form occurs manifest within the first 2 weeks of life. Later, after 2 weeks, the postnatal form manifests, and the fetal form is associated with syndromes like biliary atresia splenic malformation, which is characterized by polysplenia, situs inversus, absent IVC, and other congenital heart disease like ASD, VSD, and it has poor outcome. But postnatal form is not associated with any congenital anomalies or syndromes, and it has better prognosis.
Okay. In the syndromic form, you will have this overlap of your first 2 weeks kind
Yes.
of normal physiological jaundice also. That's one
Yes,
thing you have to
ma'am.
remember. Okay.
Yes, ma'am.
So
Okay.
then what about the pathogenesis or etiology of this biliary atresia?
Ma'am, biliary atresia occurs due to a defective embryogenesis. Normally, the biliary tree is formed from ductal plate in 11 to 12 weeks of gestation. Any malformation in that formation of ductal plate can lead to biliary atresia. It can also occur due to certain viruses, viral infections like reovirus, rotavirus, and CMV. It can occur due to autoimmune causes and also due to some genetic causes like inactivation or overexpression of certain genes.
Okay.
So coming to your USG findings, you have told, what is the expected USG findings that you will be diagnostic in this case?
Ma'am, normally we have to make sure that the baby is fasting for 4 to 6 hours. After that, normally the gallbladder should be distended. But in this cases of biliary atresia, the gallbladder will be contracted or even sometimes absent in some cases. Also, we will able to see some a triangular cord sign, that is a characteristic feature of this. The triangular cord sign, it represents the fibrotic remnant of bile duct.
Okay, so that is in detail. What is it? It's echogenic triangular
Cord sign.
cord, anterior to the right portal vein.
Yes,
So
ma'am.
what you see here is this whitish one, no? If you're able to see my arrow,
Yes, ma'am.
so that is the cord sign which you're seeing. This is the normal one where you don't see this any kind of irregular structure here, fibrotic structure. Okay. And what about hepatosplenomegaly? Do you see any hepatosplenomegaly in this case?
Ma'am, we can see mild hepatosplenomegaly, but in our case, there was no hepatosplenomegaly.
Later stages, you can have
It can
splenomegaly when you reach there, right?
Yes.
Okay. And regarding HIDA scan, you have told what is the diagnostic findings in HIDA scan? What do you find?
Ma'am,
What is the this one you're going to do, the radio tracer element? What is it you're going
Ma'am,
to
it is a nuclear medicine procedure where we use the HIDA scan is like hepatobiliary immunodiacetic acid scan. It's a nuclear medicine procedure where we use the radio tracer technetium 99. It is injected IV intravenously, and it acts like a bilirubin. The normal flow of bilirubin from it is taken up with the hepatocytes, then it is released into the gallbladder, and then it is taken into the intestine. So the tracer will also be following that pathway. And the delayed images will be taken, started at 90 minutes and will go at 4 hourly till 24 hours. So normally there is in the liver will quickly absorb the radio tracer, and the contrast will be excreted into the gallbladder and subsequently in the small bowel, and that will denote a normally functioning gallbladder. But in case of biliary atresia, where this extrahepatic biliary atretic thing is there will be delayed extraction, like there will be no tracer in the intestine after 24 hours as well. There will be non-visualization of the gallbladder and there will be poor liver washout as well.
Okay, so here we can see in these images taken from the AIMS New Delhi Bhatnagar sir's presentation, because we couldn't get the actual HIDA scan 3. I had to take from there so that in benefit of the students, so that they would see that here you're able to see some amount of uptake and the gallbladder is visualized, and it is also entering into the intestine. So this will rule out biliary atresia if this kind of picture is there. But then when the uptake is delayed or absent, and then the gallbladder is not visualized, there's poor liver washout, that means that it is a biliary atresia. But the definitive investigation is what, Shreya?
The gold standard is intraop cholangiogram.
Yes, intraop cholangiogram. So once you see this HIDA scan, it is a query biliary atresia, but then you go for intraop cholangiogram, right?
Yes, ma'am.
Okay. So, intraop cholangiogram, what are the findings that you are expecting?
Ma'am, normally intracolangiogram, in that we inject the dye in the gallbladder. And normally we'll see the flow of the bile, like we'll able to see the common hepatic duct and then common bile duct, and then the entry of that dye into the duodenum. But in this case, like the patient has biliary atresia, the whole of the biliary tree was atretic. So we won't be able to see any dye coming out in the duodenum.
Okay, so one of the slides I think you had presented our intraop cholangiogram, where there is no dye extension. Probably before we start the next section, you can just show us that. So normally what do we see is a patent biliary tree. Okay, then you see the contrast flow, which flows freely into the duodenum, and it confirms that biliary patency. Either one thing can happen is completely no flow would be there, or very minimal flow also can be there, but that is confirmatory. So the other thing is, if it is neonatal hepatitis, the bile, the injectate you are injecting itself will flush out the slush so that it clears it off. So it's also treatment. So that is the final one which will decide whether this is biliary atresia or even neonatal hepatitis. Okay. So coming to this also was taken from Bhatnagar sirs. So here we are seeing either this one is a very structured, a minimal flow is there. This also probably earliest phases of the biliary atresia. And this is a normal one. This is how it should be. So the dye is going into, you're seeing the gallbladder, the common bile duct, as well as into the intestines. This is what you're expecting. Once you see this, it rules out totally biliary atresia. That's it. So you don't go ahead with the procedure. For doing this, initially they don't go for a complete laparotomy. A mini lap can be done, and then this can be done. And then if it is present, then only you can extend that into a subcostal incision, and then the surgeon will go about it. Okay. Okay. So let's stop here and just go ahead with a couple of MCQs here. Okay. So let me share another thing. This we have finished.
So the now next MCQ for the audience is, so which among the following is the most specific marker of biliary obstruction? We are waiting for the answers.
Okay. Any answers?
Ma'am, people have answered as D, GGT.
Okay. So that's yes, GGT.
Yes, that is the correct answer. GGT is the most specific marker you can say for biliary obstruction, since it indicates damage to the biliary epithelium and is produced by the biliary, canaliculi. So among the other options, since we have already discussed that ALP can be raised secondary to the liver disease, bone disease, cardiac, or any muscle disease. So GGT is more specific. AST, ALT, then they are the indicators for hepatocyte damage. So for biliary obstruction per se, GGT is the correct answer. So next MCQ is, which of the following coagulation abnormalities is commonly seen in biliary atresia? Can we have the answers? Options are in front of you.
Ma'am, most of the students have answered it as B. Vitamin K dependent factors deficiency.
Yes, correct answer is vitamin K dependent factors deficiency. And what vitamin K dependent factors are? 7, 9, and 10. So for the absorption of vitamin K from the gut, bile salts are needed, which is not possible in biliary obstruction. Due to the obstruction, vitamin K does not get absorbed. And secondary to that, so the vitamin K dependent factors deficiency happens.
Okay. So here we done with the couple of MCQs. So Dr. Shreya and Harshita, please continue with the presentation. How did you go about subsequently?
Yes, ma'am.
This is the intraoperative cholangiogram, as I was mentioning. So you're not seeing the dye spreading beyond this gallbladder, into the intestines. Okay.
Yes, ma'am.
So the even the uptake into the intestines is totally nil in this case. Okay. Go ahead.
I'll proceed with
Anesthetic
anesthetic
concerns and how did you go about?
Yes, ma'am. The concerns will be divided into two, like patient-related concerns and anesthesia concerns. The patient concerns will be like it is an infant case, so it will be the age, physiological immaturity, risk of rapid desaturation, hypothermia, hypoglycemia, and coagulopathy. And anesthesia concerns would be difficult airway, drug dosing and selection, thermoregulation, and perioperative analgesia and hypotension.
Okay.
Okay.
Just stay there.
Achha.
Yeah.
Yeah. So when you're talking about the drugs, anesthetic concern with the drugs, so can you tell me some various drugs which are metabolized by the liver and drugs which have a high hepatic extraction ratio?
Ma'am, hepatic extraction ratio is the fraction of drug which is taken up by the liver as it comes in the blood. The drugs which are has high hepatic extraction ratio, basically they're hepatic blood flow dependent, and those drugs are like IV induction agents, propofol, ketamine, etomidate, and in opioids, morphine and fentanyl, and also all the local anesthetics like bupivacaine, lignocaine. All these drugs have high hepatic extraction ratio, and also midazolam.
Okay. So in brief, without before further going with the anesthesia management of this case, in brief about Kasai procedure. So can you tell me in brief about what are the steps of Kasai?
Ma'am, Kasai procedure has 3 steps. In the first step, they do dissection of the porta hepatis and also the mobilization and exteriorization of liver. And in second step, they will form a Roux-en-Y loop from the jejunum. And in the third step, they'll anastomose the Roux-en-Y loop of the jejunum to the functional porta hepatis, whichever is remaining.
Okay. So what do you think is the ideal age at which the child should come to you or should get operated for this procedure?
Ma'am, it should be less than 60 days. If the child comes before 60 days, it can be considered as a good outcome. If the child age is more than 60 days, the outcomes start worsening.
Okay, then what are the various outcomes you can say or factors associated with the success of Kasai?
Ma'am, if after the Kasai procedure, the baby is getting that bile stained or colic stools immediately post-op, or if there is immediately post-op or within 2 weeks, or there is near normal liver profile within 3 months of age, or there is no any complaint of any fever or cholangitis post-op.
And how much should be the bilirubin at the end of 3 months post-procedure?
Ma'am, less than 6 grams per deciliter. At least less than 6 mg per deciliter, sorry.
Okay, at 3 months.
Yes, sir.
Okay. And the number of cholangitis episodes should be very minimal or nil.
Nil, yes, sir.
Not be successful. Okay. And why do you think neonates are prone for hypothermia?
Ma'am,
As
intraoperative. First of all, neonatal have large body surface area to weight ratio, so they move susceptible to heat loss. Also, liver is a large organ and it is exposed intraoperatively, so there will be mechanisms of heat loss occurring. Also, infants depends on non-shivering thermogenesis, and
Ma'am, also the infants, they have thin skin and low subcutaneous fat and tissue.
Okay, and what about the duration of procedure?
if
Ma'am,
it's
it's prolonged surgery.
Yes, it's a prolonged surgery. So there is, and also there is exposure of the bowel loops also while they're doing the Roux-en-Y.
Yes,
So
ma'am.
there would be a lot of fluid losses and open to the. So what is the temperature that you'll be targeting at maintaining in the OT to prevent this hypothermia?
Ma'am, 24 to 26 degrees Celsius.
Okay. So what are the concerns related to hypoglycemia?
Ma'am, they are at increased risk of hypoglycemia, ma'am, because due to cholestasis already there will be decreased glycogen storage, and physiologically also the neonates have lesser glycogen storage, so they will be at increased risk of hypoglycemia, ma'am.
How do you define hypoglycemia in infants?
Ma'am, it is less than 45 mg per deciliter, blood sugar less than 45 mg per deciliter.
So how do you make sure that they don't go into hypoglycemia?
Ma'am, for that, first we'll tell the parents about that NPO status of the patient. We'll make sure that the baby is not prolonged fasting. And intraoperatively, like in NP orders, we'll tell the mother to breastfeed the baby at least 4 hours before the surgery, or if the baby is on formula feed, 6 hours before surgery, not more than that. And intraoperatively, we'll make sure we'll give the IV fluid that is dextrose containing 1 to 2.5%.
Okay, and continuously monitor
RBS monitoring.
for the introp throughout. You'll be monitoring at least every 2 hourly, correct?
Yes, ma'am.
Okay. So, how do you prevent coagulopathy preoperatively?
Ma'am, for that, we'll advise injection vitamin K 1 to 2 mg per kg per day IM at least for 3 days.
Okay, to make sure that there is no
There is
baseline
no coagulopathy.
coagulopathy.
Yes, ma'am.
Okay, and briefly describe what is HABR.
Ma'am, HABR is hepatic artery buffer response. Basically, it is a response of hepatic artery towards portal vein. Now,
Ma'am, it is an intrinsic compensatory mechanism of the liver when where the total hepatic blood flow is maintained by reciprocal changes between the hepatic artery and the portal vein. When there is a portal vein, when the blood supply through the portal vein is less, the blood supply actually physiologically the blood supply from the portal vein is 75%, whereas from the hepatic artery is 25%. But in certain cases, when the portal vein blood supply decreases, it will be compensated by the reciprocal changes in the hepatic artery. There will be increased blood supply through the hepatic artery, but vice versa does not happen, and this is thus.
Why is it so? Why does this happen? Due to what?
Ma'am, the hepatic artery has alpha receptors and dopaminergic receptors, whereas the portal vein has no, ma'am. So hepatic artery is alpha and beta receptors, and the portal vein has only alpha receptors. So that's
So
why.
vice versa doesn't happen.
No,
So
ma'am.
what about the O2 saturation of both these blood vessels? How much are the normal saturations of them?
Ma'am, the portal vein 45 to 50%, and
ma'am, the saturation of hepatic artery is just like more than 95%, and the saturation of the portal vein is around 85%.
Okay. Right. Next, we'll continue with the case discussion.
Yes, ma'am.
Yeah.
In the preoperative preparation, injection vitamin K 1 to 2 mg per kg per day IM for 3 days prior to surgery. I'll tell the patient the what people to arrange for blood and FFP 10 to 15 ml per kg. NPO should be explained for 4 hours for breast milk and 6 hours for formula feed, and written informed high-risk consent taken in view of prolonged duration of surgery, in view of any emergency central line access if required, and for post-operative ICU care and mechanical ventilation if needed.
Do you regularly give blood in these cases? Do you need to give?
No, ma'am. Regularly, we are not giving blood since the blood loss is very minimal in these cases.
Yeah, only
But
when
since it
you
is a
reach
surgery,
how much?
yeah.
More than 10% of the blood volume, that time you have to keep blood and warmed ready.
Yes, ma'am.
Yeah.
Then OT preparation. I'll make sure that the OT temperature is warm, that is 26 degrees Celsius. There's warm OT sheets and blankets, warm IV and irrigation fluids, and cotton for covering head and limbs of the baby. I'll make sure that JR circuit and MVU is there in the OT. Anesthesia workstation checked with ASA standard monitors attached. I'll check the suction machine with appropriate pressure, that is 80 to 100 in infants, with appropriate size suction catheter, that is 6 to 8 French. Airway cart with all equipments appropriate for baby's weight and age, and shoulder roll is
So
there.
how do you prepare the airway cart for this child?
I'm an airway cart. I'll make sure that the face mask appropriate for the size of baby, that is size 0 and 1 is there. Oropharyngeal airway size 0 and 1. Miller's laryngoscope blade 0 and 1, that is straight blade. And Macintosh, that is curved laryngoscope blade 0 and 1. Video laryngoscope with pediatric blade, and endotracheal tube as per baby's weight 3 and 3.5. Pediatric stellate and supraglottic airway. We have iGel here, size 1.
Okay. So how do you calculate the tube size for this baby? Okay.
Ma'am, for this baby, like we have uncuffed and cuffed tubes. For uncuffed tube, we have for a point, ma'am, that for uncuffed tube, we have weight division ratios. Like for less than 1500 grams, we use 2.5 number tube, 2.5 tube. For 1500 to term gestation, that is 3. And from term gestation to 6 months, 3.5. And since our baby lies in this range, we'll use 3.5 and one smaller tube, 1.5 smaller tube, that is 3.
Okay. And where do you fix the tube?
Ma'am, I'll fix the tube at around 8 or 9 centimeters.
What about the clinical after?
After ma'am auscultating,
After ensuring
after
bilateral?
ensuring the tube that the bilateral air entry is equal, and after auscultation.
So what standard monitors you're planning in this case?
Intraoperative monitoring will be using 2 pulse oximeters, one preferably the upper limb and one in lower limb. 5 lead.
Why do you need to?
Ma'am, because intraoperatively, when the surgeon is performing the extirpation of liver, there will be a kinking of IVC, which will lead to decreased venous drainage and decreased um, saturation, so decreased BP.
Okay. So what do you do at that instant? So you're seeing 2 pulse oximeters are placed. You're saying there is decreased plethysmograph on the lower limb. What do you do then?
Ma'am, I'll inform the surgeon
Yes.
to release
So the
retractor.
retractor, any of the retractor which they are using, or any compression with some mop that can cause this. So
Yes, ma'am.
immediately you can detect and stop it there. Okay, you'll inform the surgeon immediately so that the retractor is withdrawn, or whatever pad or mop they have placed, they can be released. Okay. Other monitors?
Ma'am, 5 lead ECG, electrocardiogram for continuous heart rate and rhythm monitoring, then an IVP, non-invasive blood pressure monitoring, and a temperature to find the core temperature of core and peripheral temperature, because the units have high risk of poor thermoregulation mechanism. Then ETCO2 capnogram, which when the patient is on mechanical ventilation, and blood glucose monitoring at regular intervals, and along with urine output monitoring, ma'am.
So how many IV lines do you place?
2 IV lines.
Okay.
Ma'am,
How do you go about this case, induction and
yes, ma'am.
vaccination?
Ma'am, for induction, 2 IV access we'll take. One was already in situ, and one we have taken after induction. And medications were withdrawn in 2 ml syringes to avoid over dosage of fluid. Then intravenous induction was performed through injection fentanyl, 1 mics per kg, that was given 4 mics, and injection propofol 2 to 3 mg per kg. And intubation facilitated with non-depolarizing muscle relaxant, that is injection atracurium, 0.5 mg per kg IV. Direct laryngoscopy done with Megill blade 1 and size 3 mm uncuffed endotracheal tube inserted and fixed at 8 centimeters. Bilateral air entry checked, confirmation through ETCO2, that is capnography, and 5-point auscultation. And after induction, RBS monitoring, RBS was taken.
Why did you use atracurium in this case? Anything specific reason?
Ma'am, since atracurium is metabolized by Hoffman elimination. The rest of the drugs like vecuronium, rocuronium, they are metabolized by liver only. So because of that, I have taken atracurium.
Okay. So subsequent is, how do you proceed with intraop maintenance of this case?
Yes, ma'am. Ma'am, for maintenance, I'll keep the baby on oxygen plus air plus isoflurane. I'll avoid N2O, as it can cause distension of the bowel. Then I'll keep the baby on controlled mechanical ventilation with tidal volume 6 to 8 ml per kg, like 30 to 35 ml we have kept, and respiratory rate 30 to 32 per minute, adjusted as per the ETCO2. IV fluids, we have made 2 in that infusion pumps. For maintenance, 1 to 2.5% dextrose according to Holiday Segar's formula. That the baby was around 4 kgs, so it made that at around 15 ml per hour. And for replacement fluid, we have taken RL at around 5 to 10 ml per kg per hour. It is an open surgery, and there's third space loss.
How did you prepare the 1% dextrose?
Ma'am, for 1% dextrose, I have taken dextrose 25 2 ml and 48 ml of RL and in a 50 ml syringe.
And when
the
do you
whole-
shift from there to 2.5% dextrose?
Ma'am, I'll shift from 1 to 2.5% dextrose if the RBS is low. And
Okay.
for 2.5% dextrose, I'll add 5 ml of D25 with 45 ml of RL.
Okay. So, how do you decide about replacement fluid? How much to give?
Ma'am,
Based
it is
on what?
Ma'am, it is based on the surgery. Like if it is a minor procedure like a hernia or hernia type of surgery or a laparoscopic surgery, at that time we are giving only 2 to 3 ml per kg per hour. But it is a major surgery and it is an open surgery, and the bowel loop was open. So for that we are replacing it with 5 to 10 ml per kg per hour.
So, what is the advantage of using RL or plasmalite? Which is better?
Ma'am,
Ma'am,
plasma light is better over RL as RL has lactate as buffer, which is hepatic metabolism. But and RL that plasma light has gluconate and acetate as a buffer, which is extra hepatic metabolism. But since our institute does not has plasma light, we are using RL here
As of today.
as of
Okay.
today. Yes, ma'am.
Yeah. Okay. So, define hypotension. How do you define it?
Ma'am, hypotension, it is classified
This
and
infant.
in this infant. Ma'am, in this infant, if the BP is less than 70, the systolic blood pressure is if it is less than 70, we will call it as hypotension.
How do you manage? Drop, suddenly you find hypotension. What do you do?
Ma'am, if there is hypotension, I'll give 10 to 20 ml per kg of fluid boluses to the baby for around 50 or 10 to 15 minutes. We can repeat it around 3 times. If after that, if the BP is not raising, then we'll shift the baby to inotropes. We will start inotropes.
So the first step would be that
Fluid
you
boluses.
would see whether your second
Pause.
pulse oximeter on the foot, whether the pleth is coming or no. If it is not coming, the first most common thing would be the retractors or your pad. If that is ensured that still your pleth is coming and still you're having hypotension, then step 2 will be your fluids.
Yes,
Correct?
ma'am. Yes,
yes,
ma'am.
ma'am.
And also look for the cause of hypotension. If it is blood loss, then you will replace by
It is
giving
blood
blood.
only.
And what is the threshold of blood transfusion we usually use?
And
Ma'am,
when blood
when-
loss is more than 10% of the total blood volume, ma'am.
Yes. Okay. So what do you think about the lines, invasive lines? Do we routinely need central line, arterial line for such cases?
No, ma'am. These invasive arterial monitoring things are reserved for cases which are prolonged surgeries and is associated with massive or large blood loss. And also, if the infant has some congenital heart diseases like in biliary atresia, splenic malformation, there is AST, VST, total anomalous pulmonary venous connection, and in Alagille syndrome there is pulmonary stenosis. All of this will require invasive blood pressure monitoring.
And ma'am, if the baby is sick or if sepsis is there,
yes, ma'am.
then also we'll supply.
Okay.
What about central line? Arterial line you have told. Yes. What about central line?
Ma'am, central line, if the baby, if we are getting 2 IV lines, then there's no need of central line. But if the baby is coming for redo surgery, or the baby is we are suspecting that the baby might go on inotropic support. If the baby is already sick, then we can plan for central
Those
line.
babies who come for a
Redo
redo
surgeries.
revision of the anastomosis or a biliary leak, were already in sepsis, having cholangitis, and the surgeon wants to revisit. These are the cases where you need both arterial and central line.
Central line.
Also, because you would be keeping prolonged NPO for the patient. Post-op, they would be NPO for at least 4 to 5 days. But then beyond that, you need to give the TPN, you have to start, because that is a stage. These are the kind of cases where you need your central line.
Central line.
Okay, and arterial line.
So what are the pain management options of such a child intraoperatively as well as postoperatively? How will you manage the pain for this child?
Ma'am, for pain management, I'll go for multimodal analgesia. For this baby, I'll plan with a caudal block that was given post-induction with 4 ml of 0.125% bupivacaine as per the age of the baby to prevent the toxic, as per the weight of the baby to prevent the toxic dose. Also, the paracetamol suppository that is given administered 125 mg, or we can give IV PCM 7.5 to 10 mg per kg, and also
lesser doses.
lesser
As
dose. Yes,
compared to
ma'am.
others, yes.
Yes, ma'am. And opioids, that is fentanyl, was given 1 mics per kg at induction, and we have repeated 0.5 to 1 mics per kg every hourly. And for post-op, we can give PCM 7.5 to 10 mg per kg, that is lesser dose, 8 hourly or 12 hourly.
So apart from this caudal block, what are the other pain management options?
Apart from this, we can give peripheral blocks like a subcostal transverse abdominis plane block plus rectus sheath block, and also we can give external oblique intercostal plane block plus rectus sheath block.
Can you give epidural also for this child?
Ma'am, epidural can be given if no coagulopathy is there, but
Yes.
well, it is controversial.
Even for caudal, you have to check for
Yes,
coagulopathy.
coagulopathy. Yes, ma'am.
Because since the coagulation was normal for this child.
That's why we have given.
This child, you gave caudal block, you didn't place a caudal catheter. Any reason?
Ma'am, there's a risk of a migration of the catheter.
What's the most common thing that you're thinking about? If you're continuing the catheter post-op, aren't you thinking about whether how would the liver function would be and coagulopathy?
Yes, ma'am.
Yes. So that was the one reason. So do you think, how long did the procedure take place?
Ma'am, 4 to 5 hours.
5 hours. Do you think the caudal block which was given was sufficient for 5 hours?
No, ma'am.
No, that is why you have given multiple things. So
Yes,
initially
multimodal.
incision major part would be covered by the caudal, followed by your multimodal.
Yes, ma'am.
Otherwise, if everything was good, the liver function is good. Some centers, they would also prefer putting a catheter, but we are not comfortable because we don't know how is the end of liver function going to be there.
Yes, ma'am.
So we didn't place a catheter, right?
Yes, ma'am.
Right. Next. So how do you proceed? Go to the next slide, please. How did you
Yes, ma'am.
proceed further? Intraoperatively?
Okay, so yes, in other words, before proceeding towards extubation, what all you will ensure, since your the surgery was uneventful in this case, there was no episodes of hypotension or any blood loss, so you were planning to extubate this child. So what all have you ensured, or what will you ensure before extubating such a child?
Ma'am, that there should be no hypothermia, no hypoglycemia, and the baby is taking spontaneous breaths and is actively moving all 4 limbs. Patient was hemodynamically stable and not on any inotropic support, ma'am.
Okay. So how did you proceed with it?
Ma'am, gentle suctioning was done. And after that, reversal was administered. Injection neostigmine 50 mics per kg, that is 0.2 mg. And injection glycopyrrolate 10 mics per kg, that is 0.03 mg IV. And after that, we have extubated the baby, when the baby was fully awake with spontaneous breaths. And we again we have kept same size or 0.5 size smaller standard tube ready if re-intubation is required. And after that, we have monitored the baby in the OT only for 10 to 15 minutes for any risk of laryngospasm or desaturation. And after ensuring that the baby is fine, moving all 4 limbs and is taking spontaneously breaths, we have shifted the baby to pediatric ICU for monitoring in warm incubator with oxygen support and monitor.
So what all you ensure while shifting these kind of infants?
Ma'am, first the incubator is warm. It is not in normal temperature. It is pre-warmed.
Pre-warmed.
Yes, ma'am. And also the baby is covered with sheets, so to prevent the hypothermia while shifting to the PICU. And also the oxygen support must be there. And there's a monitor showing the heart rate as well as SpO2.
And any drugs or airway gadgets you'll keep while
Yes, ma'am. We'll take all the emergency drugs and gadgets like atropine, ADR, and emergency equipment like laryngos, all the things of intubation, ambu bag.
Okay. So when do you think that oral feeds are restarted in such cases?
Ma'am, oral feed we generally start after 24 to 40 hours post-operatively once the bowel sounds are heard. And like until then, we'll be keeping the patient on the nasogastric tube. When we check for the bowel sounds, if it has returned, then there's the NG aspirate is minimal and the patient is hemodynamically stable. We'll start off with tropic and minimal enteral feeds at the dose of like 1 to 2 ml per kg, and then we'll be gradually increasing it as per increasing in volume and frequency as per the tolerable limit of the baby. And after post-op day 3, day 5, we full oral and enteral feed started, ma'am.
Some centers, they go a little bit slow on feeds. They would only start maybe 1 or 2 days, 2, 3 things. One, the child should not have any signs of cholangitis. So no fever, no cholangitis. There won't be any biliary leak from the drains. These things should be ensured. So not only bowel sounds, these also should be ensured before you start your oral feeds. Basically, this child would be breastfed actually.
Yes, ma'am.
So that are the ones. So what are the medications that usually are started in these cases post-operatively?
Ma'am, since these baby are at risk of cholangitis, so antibiotic is started, and also to improve the bile flow, ursodeoxycholic acid is started, and also since these baby are deficient of fat soluble vitamins because of malabsorption, so multivitamins also has been started.
So ADEK, they'll be
ADEK, yes,
replaced.
ma'am.
And UDP, it is given for how long? It is given for a prolonged period because immediately this is not going to solve the issue. It is going to be given prolonged period. Even now, I mean, a month later, the follow-up was done. The child was on ursodeoxycholic acid, correct?
Yes, ma'am.
Okay.
So what about the survival rate after Kasai procedure, or what are the success parameters which define the success for a Kasai procedure?
Ma'am, the survival rate is like 1/3 of the outcome is successful. Like since Kasai procedure is mainly a palliative treatment, 40 to 60% babies can survive for next 10 years. 1/3 of the patient will present with intermittent flow of bile with fluctuating color of stools on and off. And they will on and off cholangitis, and they can go into failure in 4 to 5 years. Only 1/3 end up in liver transplantation, ma'am.
Okay. So how do you follow up these patients? How the follow-up is being done for these patients?
Ma'am, for follow-up, we'll follow up with that liver function test, and for the history of any fever or history of any fever if there. For LFT, we'll check for levels of bilirubin, if it is decreased or still same, and also for the levels of ALP, that is alkaline phosphatase, and GGT levels.
And you'll take from the mother some history about the stool color.
Stool color
Yes,
and
ma'am.
fever both.
Yes. You will take that history and you will keep following the child so that you know whether it is successful or not.
Yes, ma'am.
Otherwise, what do you do?
Ma'am, otherwise, if the procedure is not successful, then the baby will land up into the ultimate thing is liver transplantation only.
Definitely.
So there
Definitive
should be
treatment.
an early referral of these babies to the so-called
Liver transplant
regional organ tissue transplant organization, ROTO or SOTO, the state organ tissue transplant centers, where they would be a wait list. So the child should be put on that so that the child might get an early liver transplant done. Otherwise, most of these which go on well, that is okay. But then if it is plus minus that the dissection was not done adequately and the fibrosis persists, and then they have to go for the liver transplant. So this is only a stopgap thing, the Kasai procedure. It's not a terminal procedure. That is the treatment tip. It's a palliative thing. So ultimately, that counseling is also done by the pediatric surgeon in the follow-up.
Yes, ma'am.
Okay. So
Okay. We have 2 more MCQs.
yeah, we have 2 more MCQs. If you can stop sharing.
Yes, sir.
Yeah. So which of the following is the most preferred in liver dysfunction? A very easy question. The first one who's going to answer is also going to tell me why. Let's do that. So Revati and all will be telling me who's the first one to answer.
There have been two answers, ma'am, till now. One
Okay.
is A, atracurium. Most of them have answered.
Hmm.
3 or 4 people have answered as D, cisatracurium, ma'am.
Okay, very good. Who are those 2 or 3 who answered? Who among them is the first?
Nagesh.
Yeah,
The
okay.
name is
That's
Nagesh.
the right one is when you see this list, you say atracurium, but cisatracurium is the one. Do they want to answer in the tab whether what is the reason that they said cisatracurium? Just 5 seconds we'll give them. They can type down. Why did they think it was the correct one? We have cisatracurium. In our case, we should have used on that particular day we didn't have, so we had to use atracurium. Otherwise, that would be the best. Did we get any answer from Dr. Nagesh?
No, ma'am, no reasoning till now, ma'am.
So I'll just tell in brief that cisatracurium, atracurium, either of them you can use. The very important thing is cisatracurium is more potent. So you need a smaller dose and there is lesser risk of laudanum, especially when you have kidney or liver dysfunction. The risk of laudanum and risk of seizures because of it is less. That is why it is preferred. Otherwise, both have more or less the similar one. Cisatracurium has 30% of ester hydrolysis and 70%, 77 to 80% of Hoffman degradation. Whereas atracurium has about 45% of Hoffman's. Okay, that's the main reason. Okay, the next question.
Next question, which post-operative complication is common and most
Will
be anticipated? Okay, the answer is already displayed.
So I think the answer has already been displayed.
I think so.
Yes, ma'am. Yes, ma'am, it was displayed.
Yeah, so it is
Okay,
sepsis
so
and
it was
cholangitis.
sepsis and cholangitis from all these options, since these are the most common complications we will encounter in the post-operative period.
So what are the other post-operative complications that we can see is we can see sepsis, cholangitis. They might be immediate complications that the return to OT and revision of the biliary drainage. You can have intestinal obstruction. You can have you might have fat soluble vitamin deficiencies, which you need a long-term replacement. Okay, I stop my slide sharing now. Any other questions? I think we have come to the end of the case presentation. So any discussions, any questions are welcome. Any questions in the chat box?
There are some questions in the chat box, ma'am. Dr. Ruchika, can you tell the questions?
Yes, ma'am. The first question is, can we use nitrous oxide in these procedures? Dr. Mutun has asked it.
Yeah, as we have already mentioned, any surgery when as such nowadays we try to avoid in most cases. Specifically this case, you would have bowel distension. So you don't want them disturbing your, the bowel getting inflated and because of nitrous. So you try and avoid it. We have avoided and it is best not giving air, and O2 is good enough.
Ma'am, one more question is asked. What inotrope should be used?
So Harshita, can you answer this question?
Ma'am, NORAD, we can go for noradrenaline.
Yes, NORAD is the vasopressor of choice, first vasopressor of choice in case of hypertension.
Ma'am, one more question is there. What is the role of laparoscopy, ma'am?
See, basically, when you're going with biliary atresia, the conclusive diagnosis is an intraop cholangiogram. So when you want to do a cholangiogram, usually a mini lap is done. That is what I've said initially. It is a very small incision through which they have to access to the gallbladder and then inject the dye. So in lap again, the accuracy of doing that, probably the pediatric surgeon should be telling. But here, this is what we do. A mini lap, do inject it and take a serial intraop cholangiogram. And if it doesn't enter the bowel, that we know it is conclusively it is biliary atresia. Then you can proceed extending. In our case, I mean, one more advantage. I mean, once you see that you open it, there is another advantage. You can even see the structure of the visibility of the liver with your own eyes. That is, early in the stage of biliary atresia, you won't have fibrosis and cirrhosis. In our case, even the child's, the infant's liver was absolutely normal, meaning the liver was still not affected. It was not that fibrotic. So that advantage is there. Lap, as far as I know, I've heard about no lap surgeries for biliary atresia. It is done as an open procedure because Rowan loop is taken and then the drainage is also seen.
Dr. Vijayalakshmi Madam,
Yes, sir.
actually, these lab collies, whatever the lab procedure, lab gastro surgeries, in infants, it's a very difficult learning curve
Yeah.
because the organs, the precision surgery is very, very important in these patients. And I don't think so that we can learn these surgeries by experimentation on these neonates and young children. It's a very difficult to have a very good hand in the lab surgeries on these type of procedures and that too on the kids. Because if you try practically any surgeon trying a lab procedure may take so much time that is going to enhance the morbidity and mortality also in this patient. It's always better to go with the established procedure and norms from the surgical side also, rather than experimenting with these type of young lives. So I think an anesthesiologist should refuse these things for a laparoscopic just for the sake of glory or something, sake of acquisition of hands-on skills, something like that. So that's
And
the way to move
moreover,
forward in this.
sir. And moreover, the intra-abdominal pressures would be high, and the hypotension which is caused
Yeah.
during lab would be detrimental to already, which is a damage, early damage of the liver. So that also
Yeah.
is not acceptable.
Ma'am, one more question is asked. What are the congenital anomalies associated with biliary atresia?
Can you just repeat the question? Your voice got.
Ma'am, congenital anomalies associated with biliary atresia.
Yeah, one of you can answer, Shreya or
Yes,
Harshit.
ma'am. Ma'am, like I said, based on the presentation, biliary atresia can be this fetal and postnatal. And fetal, which is quite rare, is associated with syndromic various syndromes like biliary atresia, splenic malformation, which can have congenital conditions like atrial septal defect, ventricular septal defect, TAPVC, etc. Pulmonic, then Alagille syndrome, which can have pulmonic stenosis. So all of this.
You can have absent IVC, you
Right.
can have situs
Absent IVC, yes,
inversus,
ma'am.
a lot of things.
Polysplenia.
Polysplenia.
Situs
Mostly
inversus.
they are diagnosed in the first 2 weeks. They're rare, but in the first 2 weeks. But once you cross the first 2 weeks, it is the congenital one is ruled out. Any other
Ma'am,
questions?
next question, ma'am. Can we use sevoflurane instead of isoflurane?
My question extend little further. Apart from that answering, so what is the role of TCI and TY in these patients?
Yes. Actually, TIVA actually would be much more preferable rather than going with any of the inhalational agents. So there are a few literature in which say the beneficial effect of isoflurane versus sevoflurane with regards to HABR also. I mean, the hypotension related, the hepatic dysfunction, everything in all aspects, if you see, TIVA would be much more, as an edge over inhalational. So we have done this way. TIVA pumps we are yet to procure, so probably that is one reason. So theoretically, that would have an edge. Sir, over to you. Am I audible?
Yes, ma'am. No more questions are there in the chat box.
Really, no question. That means it's such a beautiful class. Dr. Madhuri's have question. Dr. Madhuri.
Yeah, ma'am, wonderful class, and you have covered every aspect of the anesthesia management for concise procedure. I just wanted to stress on the fluid management, the perioperative fluid management, how it is very important for the outcomes. So, Dr. Shreya,
Yes, ma'am.
could we use transesophageal Doppler for fluid management? Or what is the role of goal-directed fluid therapy in these cases? How is, first of all, the perioperative fluid optimization is very important, right?
Yes, ma'am.
So if you underhydrate, what will happen?
Ma'am, underhydration will lead to intraop hemodynamic instability because there would be already blood ongoing losses happening, third space loss,
Yes,
and insensitive
correct.
losses
Yeah,
also.
you have told everything, all that you have told. And the gut perfusion will also be affected, right?
Yes, ma'am.
Yeah. And now what about if you overperfuse, what will happen?
Ma'am, it can lead to pulmonary edema and fluid retention. Um,
And the anastomosis,
anastomotic leak.
intestines will become edematous.
Edematous.
So the gut motility will come down and the baby will have paralytic ideas for more time. So the recovery will be delayed.
Delayed.
And not only that, there can be cutaneous edema also,
Yes, ma'am.
which can impair the surgical wound
Wound
healing.
healing. Wound healing is
So
delayed.
in the era of eras,
Yes, ma'am. Enhanced recovery.
yeah, so probably if you have those modalities, you can use them for fluid management if you have.
Ma'am, one question has come up.
Hmm.
Colloids or albumin, do they have any role in neonates?
Actually, the role of colloids is very controversial in neonates and infants as of now. But yes, some studies have mentioned that in case of hypoalbuminemia, people have used 4.5% albumin, but colloids are like rarely used. Maybe we are also not used. We have not used colloids in infants and neonates, and not routinely using. So we are still using crystalloids only.
Probably you could use them for volume expansion.
Yeah.
One more question, ma'am. What is the role of oral neomycin in the preoperative period?
Preoperative period neomycin has been given by certain surgeons. Mostly it is like post-operative antibiotic is continued because in view of the patient going into cholangitis plus minus these kind of issues. And that is continued for some time, at least a week or beyond, depending on what complications are occurring. If no complications, it would be stopped. Pre-op in our center, we haven't given.
I think it's a gut sterilization. Dr.
Ah.
Vijayalakshmi madam, it's a
Yes,
gut sterilization. Sometimes they use these type of
sometimes
antibiotics.
gut preparation is done.
Hmm.
Sometimes this is also done.
So in the meanwhile, next question comes. So we do a little bit honors to the hardworking people of this class. So the screen is visible?
Yes, sir. Yes, sir, it's
Yeah.
visible, sir.
Yeah. So first of all, thank you to the captain of the ship, Dr. Vijayalakshmi Sivapurapu madam. She has done a wonderful class and that too very challenging one. So thank you, madam, for being the captain and deserving HOD of AIMS Bilaspur. We are very Happy to have you on our platform here. Madam is muted, I think. Anyway, as equally important is Dr. Vrinda Chauhan. I think she was asking good questions between to the PGs, and she will be one of the most helping hand to them during the examination. I know that. So these are the assistant professor. They are the dynamic people of the the faculty group. So they are always helping to the PGs. So Harshita and Shreya, they will be having good time with her. Thank you, Dr. Brinda, and Harshita as well at already told, and Shreya. So Shreya, you have to become ISA member also, so that in front of your name the ISA number should be there. You have done ISA class, and it will be there for the next I don't know how many years. People will be looking, and people will be watching, and people will be learning from this class. Okay. So Shreya and Harshita, congratulations on good preparation for this class, and you will be doing well in your examination. And Ruchika, yourself, as well as Sh- Revati.
Thank you, sir.
Thank you, sir.
Revati, I just skipped your name, Revati and Ruchika. So you did a wonderful coordination of this class, and thank you very much for being a part of this curriculum. And you will also be, captured in this class for a long, long time. So both of you did a wonderfully good
Thank you,
job.
sir.
And I think Dr. Vijay Lakshmi madam got disconnected there. They will be connecting soon. Till they connect, we can have any other question if left. Myself and Dr. Madhuri will be able to help you as a moderator. Shreya and Harshita, don't worry.
Correct.
Any
Madam has
question
to
left?
rejoin. She has put what happened.
No, no, rejoin. Tell her to rejoin. They got disconnected. Just when her certificate came, she got disconnected.
Yeah.
I think she was climbing the stage to get the certificate, and suddenly the light went off. So it was good class, and I think in pediatric anesthesia there is
And
hardly time for a compromise, and hardly time for whatever you call learning new things on the kid. I think do you stick to the basics during your basic practice. You come across many things which you learn during those pediatric anesthesia. Everything is not in the book. If you think that everything we by reading the book is done, no. Now with so much advancements in our surgical and medical sciences, with our knowledge and newer drugs, new techniques, so new things are coming up. And as Dr. Madhuri Madam was asking about all those new gadgets, how you measure, there's all those fluids and edema and whatever it is. So many gadgets are coming up, so many terminologies are coming up, and it's better to have those things in mind. And sticking to the basics will teach you many more new things also. So what we have today, I think in 2025, and what we learned during 1999, or maybe earlier, Dr. Madhuri must be earlier. So those things, are still the same. We have not deviated from those things, because those things are still the golden standard, and our teachers have told us never to have any adventure or therapeutic misadventure on the table, especially with the kids, because that's very difficult to, you know, that's the kids won't give you time. They won't give you much time, and neonates, not at all. So, Dr. Lakshmi Madam, we were sharing your certificates. In the meanwhile, you just, I think,
No, there was a
uh,
network issue, sir. We joined through the phone now.
okay.
so anyway, I will still share you, show your certificates at least on the nationals platform, yours
Yes.
and Dr. Vrinda's. So this is your certificate for being the captain of the team. You
Thank
can
you, sir.
see.
Thank you, sir.
So,
Yes, sir.
so that's why this stage honor is very, very important. So thank you, Dr. Vijayalakshmi Siva Prapu Madam, for being the HOD and the captain of the ship of this class. And
Thank you,
as
sir.
told earlier also, Dr. Vrinda, she is most related to the PGs, most close to them. PGs always try to correlate with the younger faculty, and that's why I think their preparation goes much the what you called श्रेय हिंदी में श्रेय बोलते हैं ना, श्रेय goes to Dr. Vrinda also, much larger. So thank you both of you
Thank
for
you, sir.
being the moderator of this class, I think. And
Thank
it's
you,
a
sir.
wonderful class
Thank you
and
for
we
the
really enjoyed
opportunity.
it.
Sir,
Thank you,
thank
sir.
you, sir, for the opportunity that ISA has given us. So, thank you very much, Madhuri ma'am also.
Sir,
And these
actually,
class,
one more question has come up, sir.
okay.
Yeah.
What are the prognostic factors that affect the outcome?
I think
Okay.
I will try to answer by my knowledge and everything. And that then Dr. Lakshmi Madam will be adding to that. The first and more important is the skill of a surgeon. That's
Yes.
very, very important. Then the skill of the anesthesiologist, how many cases they have handled, and knowledge of the medicine, of the procedures. Then come the time at which the presentation of the this one neonate has come to you. Then the fourth is the degree of damage the liver has already, sustained. Then fifth of all is the other comorbidities associated with this type of disease. Sixth is that how much type of what type of infrastructure, the resources, the equipment you have got in the operation theater. Then they are just answering. I have not prepared it. Then come
May
then comes
correct,
the
sir.
duration of surgery. What type of duration of surgery was prolonged or not? Then what else you can see? Any complications, perioperative complication, they determine the factor because if it's not negligence, but these are every patient is a different to in every surgery. So what type of complications you can prevent? Hypotension, hypoglycemia, hypothermia, metabolic complication, fluid, I think overload, underload, whatever. So many. So these are the few factors. Then I think any surgical insult also that is going to happen. And what else? I think rest. I think Shreya and Harshita can add to that. They must have prepared well.
Sir, एक हाँ, okay. Shreya and Harshita.
Maybe I think that is the extra point. Less than 60 days. I think sir have mentioned more than us what we have
Sir,
mentioned.
actually, there are studies that it was shown even in the UK. Most of these children are referred to a single center where there is a single, a team of surgeons doing it repeatedly. So the outcome is better when more number of cases are done in one place. The other thing is how early the child came. That is one thing, but how well you have preoperatively optimized the child and how early you have taken up and every step in drop, how well you have managed each aspect of it, be it hypothermia or avoiding the hypotension, and as well as the post-op is a continuity. So post introp you have done well and post-op is not managed well, then again the outcome is not so great.
And more importantly, you should have a dedicated staff in the ICU or
Yes.
NICU, RICU, PICU, whatever we have got. So the dedicated staff and they should be well trained in managing these type of patient post-operatively.
Yes.
So I think these are the factors actually. These are the some factors are mentioned in the books. In the books, you always get the clinical factors, but the social, the logistic, and other factors, they come with your learning experiences in the post graduation, then senior residency, and later on in the consultancy. So these are the sepsis is, I think, sepsis is one of the complication. Somebody has written the sepsis is a part of the complication of any procedure. I think any breakage barrier during the perioperative period that can lead to sepsis, or even the surgical, some spill out of the surgery during surgery that can also lead to sepsis. And the degree of liver failure may not be able to remove all the toxins. The sepsis may be very fulminant in these type of patients. So these are
And
the things.
one important step in from the aspect of the surgeon is usually that dissection of the porta is done in a blunt fashion. They never use a cautery. The centers where less number of output is done, the moment they use a cautery, that is going to be a failure of the entire procedure. So that is one aspect, probably from the surgical aspect of it.
Yeah, I think the surgeons play a beautiful role in a good prognosis in this type of, especially the who are trained, who knows how and when to operate such patients. These are a very specialized type of surgeries, and everybody does not have the hands on them.
Yes, sir.
So I think a beautiful class, wonderful class. So we should be concluding now because it's already 8:15. And thank you both the PGs. So you will be doing very well, I know. So the confidence was good. Thank you, Ruchika and Dr. Revati. And
Thank you, sir.
thank you to Dr. Lakshmi and Dr. Vrinda Madam, both of
Yes.
you. And
Thank
more
you.
importantly, to my senior colleague, Dr. Madhuri Kurdi Madam. They were going to be the new chief editor of the journal. So thank you very much. We'll meet in the next class on Monday. So till then, it's a goodbye, good night, and we end by saying long live ISA.
Long live
Long
ISA.
live ISA.